big welcome to cohort 2023. I think this is the first webinar that we've hosted since 2023 has been onboarded. So welcome cohort 2023. If you see any of your peers, everyone just make sure to say hi to them in the chat. So let's get going here. Thank you, Brian, for being on today. And thank you to everyone for being joining us on today's webinar. Today's topic is strategic healthcare facility planning, navigating challenges, and securing funding. I think I'm getting a little bit of background noise, so I'm going to go ahead and just mute those who aren't speaking quick. Perfect. Sorry about that. This event today, as you saw, is being recorded and is also qualifying for ACHE credit. The credit survey and a link to where the recording will be posted will be sent in an email following today's webinar, and you can expect that email to come from me. My name is Caleb Lozinski, a program coordinator here with the National Rural Health Resource Center, which is providing today's webinar. If you want, you can feel free to connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. Please do remain muted unless you have a question. But if you do have a question, you can unmute your line by selecting the microphone icon in the lower left corner of your screen. And if you dialed in through a telephone number, you can press *6 to unmute that way. You can also communicate through the chat box, which is located in the bottom ribbon in the middle of your screen. If you haven't already, please take a moment to type your name, title, and organization in the chat box so we know who is joining us today. It helps us get a good feel of who is on the webinar. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the TA provider for the Delta Region Community Health Systems Development Program. The DRCHSD program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You can learn more about our commitment on our website, and there is a URL on the bottom of the slide there. All right, now before I introduce today's speaker, I'm going to go ahead and get some pre-polling questions rolling. These polling questions help us measure knowledge gained on the webinars today, so please feel free to fill those out at your convenience. As you can see there, we have Brian Hopla from Stroudwater Capital Partners. Brian has served as a trusted advisor to health executives and board of directors for over 2 decades, with a focus on developing sustainable healthcare systems from operational and financial improvement to capital investment. Prior to joining Stroudwater Capital Partners, Brian was Senior Vice President and Chief USDA Underwriter for Coyer Mortgage, and he was accountable for evaluating and approving all loan commitments as the largest healthcare lender in the USDA Community Facilities Program. Brian, again, thank you so much for joining us today. I'm going to go ahead, stop sharing, and let you kick it off.
Awesome. Thanks so much, Caleb. I'm excited to be here. I'm excited to see so many friends, old friends, since, as you said, we've been doing this for a couple decades now, and really share some of the lessons learned and best practices in being able to move forward with facility strategies. I know that there are ringers on the call here, like Mary Ellen down at St. James Parish, who have been through this process. So I'm excited to get her feedback and others around the value of this information. I'm very passionate about facility investments because really the transformation that they make in both the organizations and in the communities. So today's session is really going to be very practically oriented to share some of those stories, those best practices that we've seen working out in the field, and give folks on the call a sense of how you might be able to get started. We titled the presentation Getting Past Stop because frankly, there are just an amazing number of opportunities to take our facility plans, our long-term facility strategies, and they just don't go anywhere. So when I was working in the original Rural Health Performance Improvement Project down in the Delta, we did a lot of work on what the facility needs were. And then we realized that, again, for a variety of reasons, many of them practical and very pressing operational needs, that the facilities, it was hard to kind of get the momentum going and to keep it going. So this is a series of those lessons learned about how to make that work. The first thing I think that's important to recognize is everybody on this call has a lot of pressing, urgent situations to be attending to. People knocking on the door regularly looking for guidance, decisions, putting out fires proverbially and sometimes literally. And it's important for us to recognize that when we're thinking about facilities, that these are really long-term and important topics to serve our community, but they don't necessarily rise unless it's that fire situation to the level of our urgency. So I remember back in the day reading Stephen Covey's 7 Habits of Highly Effective People. And in that, he makes an important distinction about, as leaders, it is important that we focus on, or as people who are effective, that we focus on not just the urgent, but the important. So we don't want to sacrifice the important for the urgent. And it is a true balance. I also really liked this quotation around where we spend our time and attention as leaders really is one of our primary sources of currency. So when we are able to focus on what our facilities needs are and kind of walk the folks in the organization through a deliberate process to identify those needs, to make sure that we're planning within our financial wherewithal and our capacity, then we're able to move the ball forward. And again, I recognize that is a very hard thing to do for those of us who work in rural hospitals because of all the fires that you're putting out again. So I just want to come back to where we focus that attention really is important for us. Now, back in October, I read this article in the New York Times, which I thought was really fascinating because I thought that there were a lot of parallels to what we've experienced in rural healthcare. The premise of the article was that since the late 1960s, through administrations of all different political stripes, we've seen a declining amount of investment in infrastructure, research, and development in the United States. The thing that really surprised me from this article was that in today's travel from, say, New York to Los Angeles, so traveling across the country, actually takes a lot longer than it did back in the 60s. And when I thought of that, I thought, how could that possibly be? We have so much more technology, things just move faster generally in our life. And it just seemed weird to be thinking that, in spite of all the advances that we've been able to make, that we're kind of further behind in the things that matter to us, how much time it takes, our personal time, et cetera. So I started thinking about that and really focusing and wondering what the analogy was for our rural projects. And, here are some that I came up with. So there's an unintended consequences of not having invested in infrastructure, more roads, different types of, airplane navigation systems, et cetera, high-speed trains, take your pick in terms of the broader New York Times article. And then in rural healthcare, I think we also have a lot of unintended consequences from not having invested over a long period of time in our infrastructure. At the top of that list, and regularly what we hear is, that there's a perception that our 40, 50, 60-year-old building does not have quality care. That is often disconnected from the data itself. We're able to document that we provide great care in rural communities, but it's hard for people in our communities often to overcome that implicit bias of, geez, if the building is kind of falling down, then, or, there's challenges to the building, then what's happening inside of that building must also be poor quality. I've heard it said, maybe most directly, I wouldn't take my dog there. And unfortunately, my sense is, that there are some folks on the call here who have heard or experienced those types of feedbacks from the community relative to the perceived quality of the care that we're providing relative to the infrastructure. We've also seen, regularly, as we do in rural. I'm from a small community myself, and I know, we like to make things work. We might like to make them last as long as possible, that we layer on workarounds. So we take former inpatient spaces, which we don't have a need for anymore as much as we did back when our buildings were originally built, and we convert them into something else. So we make them offices, and so now everybody has an office with their own private bathroom and blah blah blah. Or we might take an inpatient room and shoehorn some outpatient services in there because we really need to provide that service for the community, and there's no other place to do it. Not an efficient answer to that solution for the long term, plugs the gap in the short term, but really is a workaround that creates challenges from an operations perspective. We also see a lot of challenges with aging infrastructure in being competitive to recruit staff, to recruit providers to our community who are also looking at what they have to work with, and are concerned that it's not going to be built to last. So when we did the Rural Hospital Capital Study a number of years ago, and then as we've updated that over the years, we hear very regularly that these types of investments make a big difference for being able to be successful in recruitment and retention of our staff and our providers. As referenced before, we lack a lot of space in our existing facilities to bring on new services and to provide them in ways that are, efficient and compelling for the community. So again, we might have, some imaging bolted on to the side of the hospital. An MRI truck comes up, but in order to get to that, we have to wheel patients outside into the elements in order to access that service. Very less than ideal. Again, gets the job done to provide basic level of care, but not in the way that we'd want to be providing that service. And then last but not least, our infrastructure, having 40 or 50 years old, creates structural barriers to being able to provide care in a very efficient manner. One of the most common examples that we see of that for communities that have relatively low levels of inpatient admissions and moderate levels of emergency care, they can't share staff between those two departments because they're just too physically far apart from one another from a safety perspective for staff to be going back and forth. So when new critical access hospitals are built, for example, they're often built with that efficiency in mind. So there's a common nursing station between the emergency room and the inpatient unit, so that depending on what's going on in either of those departments, the staff can flex back and forth. That's really a best practice to be able to make sure that we're able to manage our overall fixed costs relative to staffing, that folks are able to go back and forth very effectively and efficiently. So we see, some unintended consequences from having operating, healthcare in 2024 now in facilities that may have been built in 1946, 47, around that vintage. One of the things that we really like to point to is this is not the first, the folks on the call are not the first ones to go through this process. Back in 2004, 2005, my colleague Eric Schell and I were getting a lot of questions from folks starting to look at facility investments and saying, okay, yeah, this makes conceptual sense, but show us what actually happens when a community goes through, all of to the furthest extent and says, we're going to replace our facilities overall. What's the impact of that? So Eric and I, as we often do, just looked at each other and said, we have no idea, but we're going to find out. And the way that we found out was we did a survey to identify all of those facilities that had been through a replacement process and this is not to advocate that every community needs to replace its entire hospital, but the reason that we looked at those facilities in particular was because it allowed us to do a pre versus post comparison. So what was happening going into that replacement project, and then what happened afterwards? What were the results as it relates to volumes, financials, and the impact on the community? So that study was originally prepared in 2005. I know that there are folks on this call that were part of that study. Thank you for participating, and we really appreciate being able to share that information now over almost 20 years with the field. We've updated it as recently as 2022, so 7 or 8 times we've gone through, looked at the data again and said, how are these trends changing? And we've also started to delineate different cohorts. So you can see here on the slide, these are all of the replacement facilities included in the study that are part of the Delta States region, or at least Delta states. Some of these are outside the Delta region, particularly, like the ones in Kentucky over on the eastern side. But having said, not getting too far into the details, we have facilities that in the teal color that were replaced between 2009 or 2000 and 2009. Then the gold facilities were replaced between 2010 and 2019. So you can see that there's a fair number of those in both of those categories. And then in terms of results, this is not results specific to this cohort of hospitals, but really nationally. We saw a couple of interesting things in the 2022 update. The first thing that we saw was that inpatient volumes were declining. So the takeaway from that is a replacement hospital can make a lot of impact, but it's not going to make enough of an impact to overcome those industry trends that we're seeing where utilization rates on the inpatient services are going down. So we know the inpatient business is going the way of the dodo bird. And we're seeing that, as it relates to trends in the critical access hospital capital study. So on average, a 1.9% decline per year for the first 10 years in inpatient volumes. Then when you take a look at total volumes, so by inference, you start to add in inpatient or outpatient care, you can see that the story changes pretty considerably because we now go from a 1.9% decrease to a 2.9% annual increase per year for the first number of years of that project in our total volume. So we see that there is an impact that's being created around outpatient services. Makes a lot of sense when we go back to some of those structural barriers and the unintended consequences where, the business, our industry has moved to ambulatory and outpatient care, but our facilities are still set up for inpatient services. So when we are able to re-envision and recreate that for how care is being delivered today, we're creating a lot of capacity, particularly in outpatient services, and that's being used more regularly by folks in our community. Really, really important takeaway. We're also seeing a continued increase in the number of FTEs. So a 2.2% annual change in FTEs. As we're getting more volume in, we're going to be hiring more staff to take care of that volume. So this really continues to feed that economic development argument that our rural facilities are key engines of economic performance in our communities, and we're able to leverage these investments in our infrastructure into also being able to provide more jobs in the community over time. We're not doing that, however, at the expense of our business model, because the last bullet point you can see there under the summary of findings indicates that we're actually on a per unit of service basis compared to staffing, we're becoming more efficient. So we see a 1.1% decline in FTEs per unit of service. Now that, again, reflects increased efficiency, even though it's a negative number, because we're having fewer FTEs for each unit of service that we're providing. So some really important takeaways from this research that we've done over the years that really helps ground the impact that facilities can make, facility investments can make in our communities. This is not something that's only happening outside the Delta. So as was evidenced on the prior slide with all of those little X's in the teal and gold, there are a lot of facilities in the Delta that have been through a replacement process. There's, in some cases, an overwhelming number. So if I'm in your shoes and thinking about who might I reach out to learn about what their journey was like, how it worked for them, I might want to take a look at, my state. So I might want to look at, Louisiana and call up Mary Ellen and say, at St. James Parish Hospital, what'd you do? How'd you do it? How's it been working for you? Are you still happy with, having done it, et cetera? But there's also a national database, as I referenced, and we have that available here as well. So if you are interested in looking for other ways to find facilities that are like you, you can go over to the Stroudwater Capital Partners website and see this Tableau workbook here, which you see all the hospitals nationally that have replaced and are part of this capital study. It's very overwhelming to take a look at that. It's just a mishmash of places. So you can use these little slider bars and say, I want to look at just facilities that have between a 5 and a 15 average daily census. Or let's do 10 to 15 because there's still a lot. So that starts to narrow it down a little bit, right? So we now have, a smaller subset of facilities that are like me, if my census is in this kind of range. And we may want to, to drill down even further and say, we just want to look at folks that were more proximate to where we are, maybe within the last, 10 or 15 years. So we're going to look at just the facilities in 2010 to 2019. And then if we're more interested in learning about any of these facilities, we don't have to know exactly who they are just by looking at the map. We can hover over this one out in the ocean, literally is in the ocean, Martha's Vineyard Hospital. And then we can kind of see where we want to go, or, how we want to explore that hospital. Riverland Medical Center, which replaced in 2019 down in Louisiana, is reflected here. So there's lots of different ways to use this data. And one of the reasons I wanted to make sure that I included it on today's presentation is because it's a really valuable place to get started. I want to find, facilities that look as much like me as possible. Geographically is great, but there may be some other metrics that I want to look at in terms of, how big their overall business is, what their average daily census is, their average length of stay, the total size of the facility in terms of square feet. So a lot of different cuts of the onion, so to speak, to be able to take a look at finding some peer hospitals that we can learn from relative to what their journey was like and how things are working for them. I'm just really proud of the work that the team has done to pull this directory together and make sure that we get this information out into the communities. So lots of different ways to look at folks that are like you. Now I'd love to drill into some specific examples that I think are really reflective of some best practices. The first one that I want to talk about is down or over, I guess, from you in Del Norte, Colorado. This is a community of about 1,800 people, replaced their hospital initially in 2004. They used the HUD 242 program at the time as a new program to help access capital for critical access hospitals. They had about 5 days of cash on hand, and their overall business was about $10 million of gross revenue. So pretty small overall and pretty thin from a financial perspective. At the time, they did a replacement hospital. You can see here as designated by the arrows, a critical access hospital completed in 2004. Then about 6 years later, they did a clinic. So they brought the physicians and the nurse practitioners on campus by doing a clinic edition in 2010, which really helped them get some additional success, additional services locally provided. And then they did what they called the infill project, which was further renovations to the hospital and refining, and then expanding some outpatient services. They added a hyperbaric chamber, It's been really popular. Of course, Colorado's got some elevation, so people need more oxygen to help recover from wounds, et cetera. So they did this in phases. Got their replacement hospital done in 2004, built on the success of that, brought the physicians and providers on site in 2010, and then kind of did this infill project to connect it all together. That's the strategy that worked for them, which is interesting because each one's a little bit different. Now, of note here, they're also off to the side of this on their campus, finishing up as of June of this year, a wellness center with some housing on included as part of it, because like many communities, they had challenges for providing housing situations, affordable housing in recruitment of the providers. So really interesting development of this project over time, and different than this example. So this is another example, I think, of similar themes, being able to start with a replacement hospital. This is Summit Pacific Medical Center over on the coast in Elma, Washington. Very underserved community historically, some of the worst healthcare outcomes of any of the counties in Washington state. And they did this project in 2013 to replace the critical access hospital, which is right here in the foreground. And then in 2019, they did a medical wellness center, a substantial one in the background here, 30,000 square feet itself, of being able to provide some different services. So this is kind of a combination, when I compare it to the Rio Grande example, of their second and third phase. So this medical wellness center is a lot of things. It's a primary care office. It's the rehab services are there. They also have a teaching kitchen for providing nutrition services, some other wellness services, a climbing wall. So they've got a lot of bells and whistles over in this brand new facility over here. And you can see, it's on the same campus. Different strategy than we saw in Del Norte, where they started with more of the wellness orientation, as opposed to Del Norte did it more, I would say, conventionally, where they looked at a medical office building, brought some of those hospital services, enhanced those outpatient services, and then now they're just finishing up their wellness center. So tomato, tomato, not either one of these are right or wrong. But what I would say is, both of them have been right for their communities, even though they've taken different paths to develop their campus over time. So I think they're really great examples of, before we get into that, just really great examples of how we are able to start with what we have, work with our resources that are available to us, and then develop that over time as those resources grow and change over time. So the way that we think about doing that is with this, my slides will catch up, with what we would call a conceptual debt capacity. So how do you know where you can get started? Well, the simplest way, the most straightforward way that we recommend is by taking your historical financial statements and using that as the baseline of, just if we were able to continue our trends from the past 5 or so years, eliminating those COVID benefits that we got in terms of the provider relief funds, et cetera, because there were one-time funding sources. But like our underlying baseline operation, what is that generated for us historically as it relates to resources that would be available to take on some debt to make investments in our infrastructure? So the first thing that we need to start with is, what's our understanding of what's the cost of money? What are the interest rates going to be for a loan to support what we want to try to do? And that market is changing regularly. Unfortunately, last year, with some banks failing and some other things happening on the mortgage side, rates have gone up last year. We're starting to see the trends of those coming back down. So we know that rates are going to continue to be cyclical. But that's really where we need to start, is what's our current understanding of market rates? And for folks on the call, what I would offer is a good starting point would be for a 30-year series of financings, you might look at like a 4.5% interest rate in today's market for a reasonable conservative assumption to start to look at, how much your debt payments would be. That needs to be supported, of course, by our financial condition. I mentioned the trends from a financial statement perspective. We look at EBITDA as a proxy for cash flow, earnings before interest, taxes, depreciation, amortization. And then, of course, as critical access hospitals, we get to add in what the impact of the cost-based reimbursement is on the proposed project as it relates to our overall cost-based mix of interest and depreciation costs. Now, so we put those together and then create a formula or a ratio. It's called the debt service coverage ratio, which simply says, as the numerator, the top number, what is the total of the cash flow and the incremental reimbursement that will get us critical access hospitals divided by our annual debt service payments that we forecasted from what's available in the market today. That results in this ratio from a starting point of wanting to target something between 1.1 and 1.25. Now, the way to think about this number really is, because the numerator is our cash flow and our cost-based payments, and the denominator is what's going out the door. So it's inflows versus outflows. Essentially, what we're saying is a debt service coverage ratio of 1.25 is we're generating a quarter of additional cash flow and cost-based payments relative to our debt service payments. So for every dollar of debt service payments, we're going to have $1.25 of cash flow and cost-based payments. So that margin, the cushion, so to speak, is a quarter. So it's somewhere between a dime and a quarter is where you'd want to target initially. And part of this is how conservative we are. The higher this number, the better, of course. So in terms of looking at how we move forward, then we want to, oh boy, my slides are all over the place today. All right, so yes, we want our debt service payments supported by our financial condition so we can maintain a debt service coverage ratio. Got that. So if we now have an understanding of what the resources are, it makes sense to start to turn our attention to what do we need and how do we think about the need from the community going forward so that we can project where the opportunities are for us to improve our facilities and infrastructure to provide that need. This is a slide from my colleague, John Downs, who does a fantastic job of market assessments and really walking folks through this process from a master planning perspective. And the place that he starts, and that it makes sense to start, is what's our community? What's our population? What are the demographics of that population? Because each of the aspects of our community, depending on what the age mix is going to have a different utilization rate. So we know folks that are 65 and over tend to use healthcare services at a rate of about 3 times the folks that are 65 or 64 and under. So that's a key factor. If we have an older community, our underlying utilization rate is going to be higher than a younger community by comparison. Then we also recognize that within utilization rates, we've got our baseline rate, and then we've also got a lot of things happening in the marketplace. So again, my colleague Eric Schell does a lot of market updates and helps folks understand the implications of what is population health and value-based healthcare doing to our utilization. On the inpatient side, it's pushing that down pretty substantially. On the outpatient side, it's moderating, might be growing a little bit, depending on the community. We also know that there are a lot of insurance programs which are kind of resulting in steerage and other types of situations. So we need to factor in those types of considerations going forward to be forecasting into the future. How do we see the need for services changing depending on what's happening in the marketplace and with insurance programs, et cetera? We then have to take a factor of we're not the only option for where folks are getting healthcare. Sometimes in very limited, areas. We have other competition in our community. Maybe the neighboring health system has a clinic there. So, if we're looking at developing clinic services, we need to consider who's going where in our community for what kinds of services, and how is that changing over time? And then how quickly do we move people through our facilities? What's the average time that folks are in the emergency room, for example, because that will factor into how much space is needed to accommodate 3,000 visits. Might result in a certain number of need for rooms, but if we're able to have some, lean processes and move people through our systems more frequently or quickly, then we might go from needing 5 rooms down to 3 rooms, for example. And that square footage is really key to managing our overall cost of our project. So this is how we take a look at the need for services in the community. And we want to then translate that into what does that look like from a space perspective? This is where we really start to interface the market analysis with the expertise of the architects and designers who know more about, okay, if we know we have a certain number of need and we've now projected our volume going forward for the community by service line or department or by modality, what's the most efficient way from a space perspective to provide those services? And we make sure that those volumes are connected to spaces and that are sized and configured to accommodate the need from the community that we've calculated. We might be able to address that need through renovating existing spaces, taking out some walls and helping things flow better, creating some new rooms, or we might need to have new construction. And that's really an exercise that, again, is largely led by the designers and the architects based on those volume projections. So now we need to take these 2 topics, the debt capacity and the need in the spaces, and tie them back together. So the way to think about doing that is to create what I would call an allowance for construction costs. And the most important thing I think to remember in this is that the cost of the project really only is about 75% construction. So we've got a lot of other aspects of putting together a capital project, financing costs being one of those, equipment costs being another, furnitures, fixtures, and equipment. You have to pay the architects and the engineers, et cetera, et cetera, et cetera. So a good principle is to just project that you've got about 75% of the overall project budget allocated to construction. Now, we can take a look at our debt capacity, as I described earlier, and then really look at our balance sheet in terms of our cash on hand, or if we've got a funded depreciation account where we've set aside money for these types of investments. We can add that equity into the mix, total those together, take 75% of that, and that's what our construction budget looks like. And then we're really asking the experts in the space side, the architects and the planners, to create a plan for us that meets the community's needs within that funding that's available. So very few organizations, let me stop. Nobody that I've seen to this point in 25 years of doing this has been able to do it all at once. Shared that example from earlier of Summit Pacific and Rio Grande, where it's been 3 phases, and these are 2 of the probably more successful critical access hospital projects in the country, along with, I would say, like St. James Parish down in Louisiana. So we know that we need to be able to do things over time. What's the initial bite of the apple that we can take on? So we have our construction budget, which is really made up of 2 key components. The cost per square foot, largely out of our control. That's a lot of what's happening in terms of the overall construction market and the demand for construction. The size of the project in the square feet, and how much of that project is going to be renovation or new buildings. So this is very much within our control, as I just referenced on the prior slide. and might be the area that we need to kind of scale up or down depending on how much resource we have available. So in a lot of projects that we're seeing today, the cost per square foot of construction itself can be as high as $1,000 per square foot. Probably not as high as that down in the Delta, but it's good to meet with your architects and planners to really understand, what's this part that we're kind of not able to influence per se, and then how can we size the project in order to fit within our construction budget overall, given that the cost per square foot is pretty much what it is. Interesting thing about construction costs in healthcare, when you look at the national data, is from about 2012 to 2021, the annual rate of increase of those costs was 2.1%. In 21 and 22, like a lot of other costs in the United States, that jumped up a lot. It went up actually to 17% per year for those 2 years. 17% in 2021, and then another 17% on top of that in 2022. So you can see that, that's how you get up to, really high astronomical numbers with costs per square foot, is you kind of layer on 2 big years of inflation, all the supply chain stuff, et cetera. And that then, when our construction budget is relatively fixed, back to our debt capacity, puts the pressure on us sizing facilities very, very efficiently, making sure that that space is going to be used and used regularly. And it's really only what we need. So there's not a lot of room for fluff in the planning of our overall size of our projects. The good news on the construction inflation, by the way, is after 2022, so last year, 2023, we actually saw in the national data a slight decline in construction costs. I think it was a 1.6% decline in 2023 nationally for costs of construction. So that brought the number back down a little bit, but not down to where it was historically. And I think that's one of the realities that we face is construction costs will continue to inch up and climb, maybe cruise up, depending on what's happening in the overall environment. Interest rates, are going to be much more cyclical throughout time. There are going to be periods like we saw last year where they're higher. Hopefully, some periods where they're lower again, as we'll see in the future. So, really thinking about those sources of capital, what it will share is kind of break them down into 2 separate categories. Where do you get the money? Most folks are going and working with the United States Department of Agriculture and the Community Facilities Loan Program. Over the last decade or so, that program has grown from $300 million for the entire country up to over $3.2 billion for the country. So we've seen a lot of additional resources that the USDA has been investing in community facilities nationally. And the great news is a lot of those resources are going into healthcare projects. Over half of them, in fact, in their portfolio are invested in healthcare projects. They have a great rate. The current USDA direct loan rate is 3.75%. That is available for repayment of up to 40 years. So it is really cheap money. And when we're able to demonstrate in healthcare projects, as we often do, the need for those resources, it really does help increase the capacity because it reduces those debt payments that we need to. So that's our denominator in the debt service coverage. So our cash flow and our debt payments. And if we have a 3.75% interest rate, then the denominator goes down. So it helps make it easier to create a positive debt service coverage ratio, if you follow that logic. Also of note in the USDA is they have recently partnered with the National Rural Health Association to do a technical assistance program for folks that are either interested in exploring the USDA Community Facilities Program or have an existing USDA loan and need some support, whether that's performance improvement support, additional planning support, those types of things. And that is a fantastic resource that I hope everybody can be aware of and explore as needed going forward. The other government program that we're seeing some movement on more regularly now are new markets tax credits. Different program completely. These are actually investments that are made through the Department of Treasury that are capital investments into qualified areas, and they don't need to be repaid. So after 7 years of the new markets tax credit program, the money that's invested becomes equity in your project. The reason people put money in to that project is individuals and businesses put money in is to reduce their tax liability because they get a substantial tax credit as it relates to that. So good program, complex to work, but the USDA back in 2020 made some new regulations that explicitly showed how to connect those two programs together. And that's been helping people get a lot more value out of this new program. You can see there's about $3.5 billion annually for the country in the program, and the regulations indicate that at least 20% of that needs to be spent in rural communities. So we know that that's another $700 million there of additional resources available for our projects. The note here, and a really important note, is that these allocations are competitive. So you're really showing your project the impact that the project's going to make as it relates to the services you're going to be able to provide, the number of folks that you're going to be employing initially and over time, and presenting that data to these investors and really saying, we think that your money is best invested in our community for these particular reasons. Would be remiss to say from my folks who work on the Wall Street side that there are tax-exempt bond financing programs that are available. Most of the time in rural communities, these have been hard to access because Wall Street is what Wall Street is, and they define a small hospital as anything other than $125 million in operations. So you can tell, that's a pretty big hospital, for a very big hospital for any of our rural communities. But there are opportunities to explore that on a limited basis. And in fact, last year, when interest rates were going up with banks, we did see some folks start to move into exploring and getting financing through the bond market. So these are bonds that are sold to investors, institutional investors who manage like pension funds, things like that. They may be backed by taxes, but they don't have to be. You can pledge the ongoing resources of the organization, which is called the revenue bond. The caveat with that is the better the backing, the lower the interest rate. So if we're backing our bond with our business, the revenues of the facility, the interest rate is going to be higher, and that will be what's typically called a non-rated bond, or what's commonly called a junk bond. And the rate for that will be folks that are willing to take that risk, but they're going to expect a higher interest rate to offset that risk. The interesting thing is, for those critical access hospitals that are affiliated with healthcare systems, that additional scale, does help bond investors get a lot more comfortable with the projects. Or if the project and the bond repayment is supported by taxes in the community, that also helps a lot. I could continue to talk about bonds and my frustrations with Wall Street in not understanding cost-based reimbursement, not valuing rural communities, et cetera, but I wanted to at least reflect it as an option that may work in some communities, that some of your communities. So that kind of leads us to, is there a question?
Yeah, just a quick, I'll pop this in here. Blake Kramer, Franklin Hospital CEO there in Louisiana. I had a question in the chat that I wanted to bring to your attention. With all the speculations over how the payment system will be changing, death of FFS, increased capitation, etc., are there any adjustments made to the revenue debt coverage projections in these types of projects? it seems that the risk is much higher than what traditional formulas would indicate, given all the factors.
Yeah, thanks, Kate. It certainly is something to be mindful of and to consider. I would put that in the same category of when you're kind of going through the initial debt capacity study. I mentioned, you look at trends in the financial conditions. So we're not just taking, our last year and saying we'd be able to continue that going forward indefinitely. We want to say, if we've been increasing regularly, then maybe we do continue to increase a little bit in the future. Or if things have been flat, then let's keep it flat. But to the point of the question, Kate, what I would say is we may also want to discount some of those future cash flows based on what's happening in our marketplace about, capitation, for example, that might limit some of those resources going forward. And if we've got any level of grounding of how much that might be, then I would just say we want to make some adjustments going forward, because what we're really trying to figure out is historically, based on what we've been able to offer to the community, we've been able to generate X number of resources, and the debt capacity is a starting point for us to assume that we can do that going forward. And to the great question here, if that's not a solid assumption, and we need to, assume we're only going to have, 85% of what we had historically because of some of these changes, then we want to take that off the top so that we're not overestimating our debt capacity. It really does provide a starting point and not the end point, but it's a really important starting point because it gets us in the right ballpark. What I would say is outside the Delta, we were recently introduced to a hospital in Texas that is in a typical critical access hospital sized facility. And their replacement facility project was $80 million in cost. And my first question to them was, does that fit within your debt capacity? And they said, what's the debt capacity? So really what happened was they hired an architect, went through all of that need piece, did a lot of dreaming, did a lot of meetings with their staff, did all the things to engage folks around, a new facility investment, but didn't do that connected to their reality. They did not do that in any way that was tied back to, could we even afford $80 million? Or can we, is it really more $20 million that we can afford? And we need to figure out what the best use of that $20 million is to get us started. So that's the purpose of the debt capacity. Is it's the beginning point so that we can get past stop with the planning, start some of the conversations in the communities, and frankly not lead to a lot of frustration with our staff. Because as I was meeting with back 15 years ago, working on the RHPI project, for example, meeting with folks in the Delta around their facility plans, I was always surprised that there wasn't a level of enthusiasm. Let me say it that way. I'd be meeting with a department manager and say, you have an exciting opportunity to make some investments in your facility. We've done a debt capacity. We know how much you're going to be able to spend. What do you think is most needed? And the most common response that I got was, why is this going to be any different than the 4 times we've had these conversations before that have not led anywhere? That's stop. That's getting to stop. That's, we know we have a lot of needs, but we don't know if we don't know what we can afford from the outset, then it's an intellectual exercise and it's not going to go anywhere. We're going to have a lot of excitement created, around what could be different, and then nothing happens. So let's not do that. And I think, again, thanks for interrupting, Kate, because it is a great question it's a starting point. And if we know that some changes are coming down in the future relative to reimbursement, in our state or in our community with our insurance contracts, et cetera, then let's just take that off the top in the debt capacity analysis. Let's be conservative with where we're starting from so that we're planning within those guardrails of what we think we're going to be able to afford. Because that's only based on the past. That doesn't look at what the impact of the project is itself. And I don't want to suggest that we want to do projects that don't create an impact, but we're taking that off the table, and we're going to allow that to come out in the feasibility study process, which I'll talk about here in a moment. So I know that we're running short on time, so I'll just wrap things up by saying, everything that I have shared today on today's webinar is really what we would call in the 7 steps for highly successful facility investments, base camp. We use this analogy of climbing a mountain because for those of you that have been through a process like this, you know that it feels like climbing a mountain, and that what we want to be able to do is know what the path is on that mountain. So we start with getting ourselves ready, having a debt capacity. We look at those community needs in the very first step, as I talked about today. We want to make sure that where we're planning on building meets all of the environmental regulations. USDAs are pretty substantial. And then we really take the next step of going into the financial feasibility in much more depth. It's a requirement for any source of financing. USDA's requirement is that is an examination level financial feasibility study. And we need to test and assess and retest and assess going forward with some independent consultants and accountants to say, yeah, the assumptions that you've made in planning this project are reasonable. They're within the industry's best practices. And we are going to sign off to say that this project looks like it's good to go. The lenders are also going to expect that you have sufficient collateral to offset how much you're borrowing. That's through an appraisal process. And then in USDA's process, after these requirements are met, the what's called the preliminary architectural report, the environmental report, the financial feasibility study, and the appraisal, then you can submit a full application to the USDA that they'll review. You wait for a good period of time before you get to the summit. You answer a lot of questions. There's some back and forth of helping them understand what you're intending to do. And then ultimately, when you get to the top of the mountain, you're able to secure a commitment from USDA for that financing, hopefully as much of that at that 3.75% rate as possible. So that is the entirety of climbing the mountain around financing for rural healthcare. And I think I have about 60 seconds left for any additional questions, Kate or Caleb.
Yeah, another question did come in from Todd Epler with DeSoto. Does Stroudwater Capital act as a bank for interim financing?
We do not access as a bank. It's a great question. Thank you. What we do and the partners of Stroudwater Capital Partners is we work with a number of different lenders who are in these programs and really try to help provide some options for folks to make your own selection around that. We also are different from Stroudwater Associates in the sense that we work with those lenders to have them paying us for services to support the development of your project, as opposed to my friends over on the other side of the office here who are charging a consulting fee. So a little different. Thanks so much for that question, Todd.
And it is the top of the hour. I'm just going to go ahead and launch some post-polling questions. Feel free to ask any questions. If we don't have time for it too, feel free to email it to me and we can have that discussion. I'll send it over to Brian. Otherwise, again, thank you everyone for being here today. If you don't have any questions after you fill out that post-polling, feel free to have a fantastic lunch.